Huang. Yes, you heard that right. I'm Robert Huang, and I'm introducing Robert Huang. Same name, no relation. In all seriousness, Rob is another amazing rising star in our field. He's an instructor and advanced endoscopist at Stanford. His clinical and research interests is really focused on gastric cancer and premalignant lesions of the upper GI tract. And a fun fact that I recently learned at one of our division meetings, he actually submitted not one, but 2 K Award grant submissions. And some of us in the room know how difficult it is to just submit one. But to add on top of that, he got a perfect score. So he is funded by Career Development K Award. Congratulations. Welcome, Rob.
Well, Robert, thank you for that introduction. Let me just say a little bit about Robert. When I was an intern, he was a fellow in GI, and he actually mentored me on my very first publication in residency. It was a case report about bleeding after an LVAD placement. And Robert is a fantastic researcher himself. He actually just got his first R01 award, and he's been a role model for me. And now that there are 2 Robert Huangs walking around Stanford, it's a little confusing. I often get confused for Robert. And let me just say, Robert, it is a privilege to be confused for you. So Allison invited me to give this talk about premalignant lesions of the upper GI tract. And initially she said, well, if you want, you can just talk about gastric cancer, because that's what my research interests are and my funding is in. But she said, but I said, no, I actually would like to talk about both esophageal and gastric cancer. And I think you'll see that when we look at the evidence base for each, one is clearly very well developed and one is clearly very underdeveloped. And I think that juxtaposition of how we approach esophageal cancer and gastric cancer is actually quite valuable. And at the end, I'd like to put this all in the context of providing high-value care to our patients. First, my disclosure, I'm supported by the National Cancer Institute. So let's first start with esophageal cancer. So these are temporal trends in the incidence of esophageal cancer in the United States, and this is broken down by esophageal adenocarcinoma and esophageal squamous cell carcinoma. The risk factors for each are different. The incidence of esophageal adenocarcinoma has been gradually increasing over the last 20 years. However, more recent data suggests that this increase has at least started to slow, partially as a result of better control of the obesity epidemic in the United States. By contrast, esophageal squamous cell cancer incidence has decreased over the last 20 years. I know we all know that esophagus cancer is more common among men, but sometimes figures put this into perspective. This is the trend in incidence of esophagus cancer by sex, and as you'll see, males really are predominantly afflicted by esophagus cancer at a rate of about 5 to 1. Barrett's esophagus, a common diagnosis that we as gastroenterologists encounter. Barrett's esophagus is a change in the normal squamous epithelium of the distal esophagus to columnar-line metaplasia, and an established risk factor for esophageal adenocarcinoma, GE junction adenocarcinoma, as well as cardia-type gastric cancer. Risk factors for Barrett's esophagus include long-standing reflux disease, male sex, central obesity, age over 50 years, tobacco use, current or any lifetime tobacco use, white race versus Hispanic and or Asian race, family history of Barrett's esophagus or esophageal adenocarcinoma. Interestingly, alcohol consumption has not been demonstrated to be a significant risk factor for Barrett's esophagus, and in fact may actually be protective. Also interestingly, Helicobacter pylori infection may actually be protective against Barrett's esophagus. Why we believe that is that in advanced cases of Helicobacter pylori infection, a state of relative hypochlorhydria results, which may protect against neoplastic progression. It's always good to have a sense of numbers to counsel your patients when dealing with precancerous lesions. The annual risk of progression from Barrett's esophagus onto esophageal adenocarcinoma for all comers, irregardless of the length of the Barrett's, is about 0.25% for the general population. If you have some low-grade dysplasia, that increases to 0.2 to 1.2%, and for high-grade dysplasia, 4 to 8%. So as part of this talk, I had the opportunity to review guidelines for management of Barrett's esophagus from 3 societies, the ACG, the AGA, and the ASGE. Now, many of these recommendations are fairly close, but in a couple of points, they differ quite dramatically. So let's go through each stage of the management of Barrett's esophagus and see what the guidelines tell us. So first, whom should we screen for Barrett's esophagus? We should not be screening the general population for Barrett's esophagus. The ACG recommends that screening for Barrett's may be considered in men with chronic, that is defined as greater than 5 years, or frequent, defined as weekly or more, symptoms of GERD with 2 or more of the following risk factors: age greater than 50, Caucasian race, central obesity, current or past smoking, and a first-degree history of Barrett's esophagus or esophageal adenocarcinoma. In females, however, screening can be considered in individual cases as determined by the presence of multiple risk factors. By contrast, the American Society of Gastrointestinal Endoscopy states that there is insufficient evidence on the effectiveness of screening for Barrett's esophagus. However, if screening endoscopy for BE is performed, we suggest a screening strategy that identifies an at-risk population. An at-risk population is defined as individuals with a family history of EAC or BE, or patients with GERD plus at least 1 risk factor. So there's a slight difference in opinion here about whom we should screen for Barrett's esophagus. In my opinion, the ACG recommendation is slightly more structured. Diagnosis and staging of Barrett's esophagus. In general, a normal Z-line or a Z-line with less than 1 centimeter variability should not be biopsied. Sometimes in my clinic, I'll see patients referred for intestinal metaplasia at the GE junction, but there's less than 1 centimeter variability. So what to do with these patients? I actually don't survey these patients because, in my opinion, they probably shouldn't have been biopsied to begin with. Barrett's esophagus should be diagnosed when there is extension of salmon-colored mucosa extending at least 1 centimeter proximal to the GE junction. In the presence of Barrett's, endoscopists should describe the extent of metaplastic changes using the Prog classification, the location of the diaphragmatic hiatus, the GE junction, and the squamocolumnar junction should be reported. And finally, the location of all visible lesions, which includes nodules and ulcers, should be clearly stated, including the distance from the incisors and the laterality. This is the Prog classification. The point of reference is the true position of the GE junction, which is defined as the top of the gastric folds, and that's set at 0 centimeters. The maximal extent of circumferential Barrett's should be defined, and the maximal extent of any metaplasia should also be defined. So in this case, the circumferential extent of metaplasia is 2 centimeters above the top of the gastric folds, and the maximal extent of metaplasia is 5 centimeters above the top of the gastric folds. Therefore, this is a C2 M5 segment of Barrett's. Now, what about surveillance of Barrett's esophagus? Patients should enter a surveillance program only after counseling on risks and benefits per the ACG. By contrast, the ASGE states that surveillance is recommended. Both societies state that routine use of advanced imaging other than NBI is not recommended. Both societies also recommend against the use of routine confocal laser endomicroscopy. Mucosal abnormalities should be separately sampled, and preferably by EMR. So what that means is that if you see a nodule in a segment of Barrett's, you should not be separately biopsying it, but rather you should remove the nodule by EMR. And that provides both a diagnostic and a therapeutic maneuver. 4-quadrant biopsies every 2 centimeters if there is no history of dysplasia, and every 1 centimeter if there is a history of dysplasia is recommended, the so-called Seattle protocol. Biopsies should not be performed in areas of active esophagitis until mucosal healing. And finally, in non-dysplastic Barrett's esophagus, a 3 to 5 year interval is recommended. So this is an example of the Seattle protocol. Beginning 1 centimeter above the top of the gastric folds, 4-quadrant biopsies are taken every 2 centimeters until the top of the maximal extent of Barrett's, in this case a C5M7 segment. Moving along to the diagnosis of dysplasia. Dysplasia should always be confirmed by a second pathologist with expertise in GI pathology. And patients who are indefinite for dysplasia should undergo optimization of acid suppression therapy and undergo repeat examination in 3 to 6 months. In a subset of patients, a diagnosis of low-grade dysplasia will be downgraded upon review by an expert GI pathologist to non-dysplastic Barrett's. Per the AGA, these patients should be managed as non-dysplastic Barrett's. In Barrett's patients with confirmed low-grade dysplasia, repeat upper endoscopy using high-definition white light endoscopy should be performed 8 to 12 weeks after maximal acid suppression therapy. That is an AGA-only recommendation. On the management of dysplasia, in patients with low-grade dysplasia, endoscopic eradication therapy is preferred over surveillance per the ACG. However, in patients who place a high value on the avoidance of adverse events, surveillance may actually be preferred per the ASGE. What that goes to show is that you really have to have a frank conversation with your patient before embarking on endoscopic eradication therapy. It may be appropriate in some patients who have life-limiting conditions to continue surveillance. So dysplasia alone does not necessarily prompt eradication therapy. In patients with high-grade dysplasia, however, the societies are more unified in the recommendation that eradication is preferred over surveillance. As I discussed before, patients with nodularity in a Barrett's segment should undergo EMR of all visible lesions, no matter how subtle. In fact, some people think that if you look carefully enough, any area of dysplasia should have a visible lesion, even if very subtle. In patients with nodules, routine use of EUS prior to EMR to differentiate mucosal from submucosal disease is discouraged. In patients where the EMR specimen demonstrates neoplasia or cancer at the deep margin or with evidence of lymphovascular invasion, surgical referral is recommended. And in Barrett's patients with visible lesions who undergo endoscopic resection, we suggest ablation of the remaining Barrett's segment compared with no ablation. As of 2016, radiofrequency ablation was the preferred endoscopic ablative therapy. Now, since that time, additional data has come out about other methods of ablation. And for instance, cryoablation, which many of the gastroenterologists here in Northern California had a critical role developing, looks very promising as a method of ablation. Regarding post-ablation surveillance, patients who finish endoscopic eradication therapy should be enrolled in an endoscopic surveillance program compared to no surveillance, and all of our professional societies agree on that point. However, they slightly disagree on the tempo of surveillance. The AGA recommends patients who have achieved complete eradication of Barrett's should undergo surveillance every year for 2 years, and then every 3 years thereafter with Seattle Protocol. However, the ACG states that in cases of cancer or high-grade dysplasia, every 3 months for 1 year, every 6 months for the second year, and annually thereafter. For low-grade dysplasia, every 6 months for 1 year, and annually thereafter. Finally, in terms of management of reflux, patients with Barrett's should receive once-daily PPI therapy per the ACG. Routine use of twice-daily PPI therapy is not recommended unless necessitated by poor symptom control. Aspirin and nonsteroidal anti-inflammatory drugs should not be prescribed as anti-neoplastic therapy. And finally, anti-reflux surgery should not be pursued in patients with Barrett's esophagus as an anti-neoplastic measure. However, in patients with poor symptom control, surgery can be considered. So everything I talked about prior to this was Barrett's esophagus and esophageal adenocarcinoma. What about squamous cell cancer? Well, there are no recommendations for screening for esophageal squamous cell cancer in the United States. Esophageal cancer actually has highest prevalence in the Asian esophageal cancer belt. In fact, the majority of esophageal cancers in Asia are of the squamous cell variety. Smoking, alcohol, and especially drinking of alcohol in Asians who flush or turn red, which about 40% of East Asians do, achalasia, tylosis, infection with human papillomavirus, and a history of head and neck cancers are risk factors for squamous cell cancer. Squamous cell cancers tend to be more subtle to diagnose on endoscopy. So the first part of my talk focused on esophagus cancer, and next I'd like to talk about gastric cancer. The incidence of gastric cancer in the United States is overall quite modest. We're at about 6 per 100,000. High incidence nations include Japan, about 40 per 100,000, and South Korea at about 50 per 100,000. Other high incidence nations that some people aren't aware of are actually the post-Soviet world. So Russia, Belarus, Eastern Europe have very high rates of gastric cancer, as well as mountainous or Andean Latin America. So we went over all of those recommendations for Barrett's esophagus and the screening, surveillance, management of Barrett's esophagus. And as you'll see, there are actually very, very few recommendations for the screening and surveillance of gastric cancer. However, interestingly, there are actually 10,000 more cases of gastric cancer each year than esophagus cancer. While the incidence of gastric cancer in the United States as a whole is modest, this belies the fact that there exist certain high-risk subgroups in the United States. The incidence of gastric cancer is lowest among non-Hispanic whites. American Indians, Hispanics, and non-Hispanic blacks have an age-standardized incidence for gastric cancer roughly double that of non-Hispanic whites. Asians, in aggregate, have an incidence approximately threefold higher than non-Hispanic whites, but certain high-risk Asian subgroups, such as Korean Americans and Japanese Americans, have incidence 4 to 6 times higher than non-Hispanic whites. These differences are magnified when we take into account the anatomic location of the cancer. As I mentioned, cardia-type gastric cancers have a biology and risk factors more similar to esophageal adenocarcinoma. In this study by Shalja Shah, based on the California Cancer Registry, the incidence of gastric cancer was stratified by anatomic location and by race. For cardia-type gastric cancers, non-Hispanic whites had the highest incidence. However, when looking at non-cardia gastric cancer, the incidence rate ratios for non-cardia gastric cancer was approximately double that of non-Hispanic whites among blacks, 3 times higher among Hispanics, 5 times higher among Chinese, and an astounding 13 times higher among Korean Americans. So clearly, there exist high-risk subgroups in the United States that may benefit from screening or surveillance. So is this an opportunity for us to improve outcomes? This is a study we published in Gastroenterology last year, comparing the stage of diagnosis and outcomes in 3 nations, South Korea, Japan, and the United States. South Korea and Japan both have structured screening programs for gastric cancer utilizing either biennial radiography or endoscopy, and the United States has no structured screening program. In the study years, there was approximately twice the rate of localized cancer diagnosis in South Korea and Japan, 50% compared to the United States at 28%. And survival in these countries from gastric cancer was approximately double that of the United States as well, 67% and 65% versus 32%. So what are some risk factors for gastric cancer? Modifiable risk factors for gastric cancer include historical or current infection by Helicobacter pylori, atrophic gastritis, intestinal metaplasia, or other dysplastic lesions, a diet high in salt and salt-preserved foods, smoking, and infection with the Epstein-Barr virus. Non-modifiable risk factors include Asian, Black, American Indian, or Alaskan Native race, and Hispanic ethnicity, family history in a first or secondary relative, and hereditary cancer syndromes including Lynch, FAP, and Li-Fraumeni. I'd like to briefly introduce the idea of Correa's cascade, named after Pelayo Correa, a researcher at Vanderbilt University. Helicobacter-induced gastritis causes gastric cancer, dysplasia and gastric cancer over decades, not overnight. And so this histologic progression starts with chronic inflammation of the stomach. This leads to thinning of the gastric wall, which we term atrophic gastritis, followed by replacement of the normal gastric epithelium with intestinal-type mucosa, which we term intestinal metaplasia. We believe intestinal metaplasia to be an irreversible mucosal condition which predisposes to gastric cancer for the rest of a patient's life, and then from there on to dysplasia and gastric cancer. So, does screening work? And the answer is probably. This is a systematic review and meta-analysis published in Gastroenterology in 2018. In this study, they looked at 10 observational studies, both nested case control as well as cohort studies, where the exposure was receipt of endoscopic screening and the outcome was cancer-specific mortality. They found an approximate 40% reduction in gastric cancer-specific mortality if you had received endoscopic screening. And this effect remained robust among both men and women, and in both case control studies and cohort studies. Now, one criticism of this data is that it is all based on East Asian studies. There exists very little data from Western nations about endoscopic screening. And another criticism of this data, it is all observational in nature. There have been no prospective clinical trials evaluating the effect of screening. Additional data, ecologic data from East Asia, which suggests an effect of screening, is the stage of diagnosis. So in this study, which we published last year in Gastroenterology, we compared the stage of diagnosis in South Korea, where a national screening program was initiated in 2002, versus the United States. And we saw that the proportion of early gastric cancers increased from 39% the year prior to the adoption of the program to 73% in 2016. By contrast, the United States basically hasn't budged. Now, this is ecologic data. There may be multifactorial explanations for this trend. However, there does appear to be a shift in stage of diagnosis, which is coincident with national policy changes in that country. So, what are our existing North American, United States recommendations for endoscopic screening and surveillance? Very little. So, for gastric cancer screening, the ASGE, in a 2015 Standards of Practice document, states that endoscopic screening for gastric cancer in first-generation immigrants from high-risk regions defined as East Asia, Russia, or Eastern Europe, and South America may be considered for those age 40, particularly if there's a family history of gastric cancer. But that recommendation was just in the body of the text. It wasn't a separate standalone box recommendation. There was no level of evidence associated with that. Regarding surveillance of IM, the ASG in 2015 states that endoscopic surveillance of patients with atrophic gastritis or IM coupled with an increased risk of gastric cancer because of race, ethnicity, or extensive anatomic distribution, can be considered for surveillance, but no surveillance interval was given. And finally, the most recent guidelines from the American Gastroenterological Association last year initially stated that they recommend against routine use of conditional surveillance in patients with IM. And that was it. In the initial version of the recommendation, which was released for public comment. Upon release of this recommendation for public comment, we actually initiated a social media campaign to try to change this recommendation. And so this latter part here of the recommendation was a result of that successful campaign. So they nuanced their recommendation by saying patients with IM at higher risk for gastric cancer who put a high value on but potential but uncertain reduction in gastric cancer mortality, and who put a low value on potential risks of surveillance may reasonably elect for surveillance. And then they listed a number of conditions where patients or individuals are at increased risk for gastric cancer. So I think that was a partial win, at least, that we can get the caveat placed into the recommendation box. Finally, what about Helicobacter testing and treatment? The ACG recommends HP testing for patients with active peptic ulcer disease, past peptic ulcer disease, a history of malt lymphoma, a history of resected gastric cancer, and for patients under 60 with uninvestigated dyspepsia. We think that these recommendations should be broadened. The Houston Consensus Conference was a panel of H. pylori experts convened in Houston in 2018, and they recommend, in addition to the ACG recommendations, that we should be testing and treating patients with a family history of gastric cancer. There's outstanding clinical trial data to suggest that that saves lives. Patients who are first-generation immigrants from high-risk areas, and patients of Asian, Hispanic, and African-American racial or ethnic groups. So finally, in putting this in the context and the framework of high-value care, as we increase the intensity of cancer screening, we both increase the value of screening in the form of decreasing cancer-specific mortality, but we also increase the harms and the costs. Harms for endoscopic screening include the overt harms of performing endoscopy, endoscopic complications, but also potentially psychological harm to the patient, and then the cost of the procedure. Optimal value is provided in that middle column when we can maximize cancer-specific reduction mortality without increasing the costs and harms to the patient. And we think that we have enough data right now about how high-risk subgroups based on race, based on ethnicity, based on the existence, the distribution of precancerous lesions, that we can offer tailored screening programs to individuals in the United States and improve high-value care. Sorry I went over by about 4 minutes, but I'm happy to answer any questions.
In patients with incomplete intestinal metaplasia and extensive, how often do you surveil? Every 3 years, 4 years, how often?
So if the patient has both extensive and incomplete intestinal metaplasia, that would be the highest risk group. And so I actually survey these patients every 2 years. Yeah, but there's not good data to suggest that surveillance interval, but that is the highest risk group, incomplete and extensive.
Perfect. Thanks so much, Rob. Yeah, thank you so much. Well, thanks everyone for sticking it out. We have one more session.